Good evening, everyone. First of all, I thank Dr. Deepankar Datta and the organizing committee of EZECHO for inviting me to participate in this meeting. Today, I'm going to talk about echocardiographic assessment of cardiac function in the presence of AF. This is something which is important but quite challenging. So here we have a 65 years old gentleman, hypertensive. He was known to be having AF for the last 3 years. His coronary angiography 3 years back was normal. He presented to our hospital for knee replacement, and from there he was referred to us for preoperative cardiac evaluation. As we can see here, his LV size appears to be normal, LV systolic function appears to be normal, RV is mildly dilated. There could be some LV hypertrophy, but not gross. But both atria are hugely dilated, and he, of course, had atrial fibrillation. Now, the question is whether this AF in him is just a consequence of aging and hypertension related atrial remodeling with some degree of diastolic dysfunction, or it was a more advanced diastolic disease of the left ventricle like RCMP, or it was a primary left atrial cardiomyopathy. Answers to these questions are important not only for diagnostic purpose, but more importantly from prognostic standpoint. As we know, increased E over E prime in these patients have been shown to be associated with increased mortality, and many other echo parameters are associated with adverse outcomes. And it may have therapeutic importance also, like use of diuretics. And in this particular patient, EF appeared to be normal, but had it been reduced, then we would have been thinking about ICD also. So for that also, we need to have an accurate assessment of LVEF. However, assessment of cardiac function in AF is quite challenging for many reasons. Most important of them is significant beat-to-beat variability, which is universally there in the presence of AF. And because of this variability, it becomes very difficult to accurately and reproducibly measure any echo parameter. And the problem is even bigger for the parameters that require integration of information from different cardiac views like E over E prime or Simpson's method or GLS. Also, when AF sets in, some of the parameters that we routinely use for LV diastolic function assessment become irrelevant or absent, like E by A ratio, because there is no A wave in AF, and LA enlargement also becomes less relevant because AF itself can cause significant LA enlargement, even in the absence of diastolic dysfunction. Another problem that we face is that when the heart rate is very fast, then not only measurement becomes difficult at that fast heart rate, the waveforms also become quite indistinct and chaotic, and it becomes really difficult to make out where to measure, what to measure. And finally, mitral valve disease is quite commonly present in these patients uh, because they are often elderly and mitral annular calcification is common. So this adds another layer of complexity to this whole process. So what to do? The first question that we need to answer is which cardiac cycles to measure and how many cardiac cycles to measure. The 2016 ASC guideline document on diastolic function recommends that we take average of 10 consecutive cycles. This appears to be the most reproducible and accurate measurement for this purpose, but it is clearly impractical unless we have echo machines that can automatically do that. So the alternative is that we take three non-consecutive beats with cycle lengths which resemble that of the average heart rate in that patient. Or some other investigators have suggested that we use RR intervals that match heart rate of 60 to 80 beats per minute and take three beats and take average. Now, although guidelines recommend this, but there is a problem here, and I'll explain this the problem here in this spectral Doppler pattern from the LVOT. So see here we have a long cardiac cycle. Long cardiac cycle will mean better LV filling. If LV filling is better, then through Frank-Starling mechanism, the next beat systolic function is going to be much better. And this is what we see here. LVOT velocity is quite tall. And in the subsequent cycle, which is a short cycle, LVOT velocity is reduced, and next cycle again increase because the cycle is longer. So we see a very clear relationship between cycle length and the systolic function of the next cycle. This is something which we have studied in cardiac physiology also, and many studies have shown this, and they have suggested that instead of looking at the RR interval of this cycle where we are making measurement, it may be more important to look at the RR interval of the preceding cycle. So what we should do is that if this is the target cycle that we want to use, then we look at RR intervals of these two preceding cycles. We name this as RR1 and this as RR2. When the ratio of RR1 to RR2 is 1, which means that we are encountering a stable cardiac rhythm, then this cycle is going to give us the most accurate measurement. And numerous studies have shown this. This is one example. So in this study, the investigators looked at 50 patients with AF. They did 30 seconds recording of tissue Doppler for measurement of strain in the interventricular septum. What they found was that increasing RR1 was associated with better strain because longer RR1, better systolic function. And when the ratio of RR1 to RR2 also increased, strain increased with that. So basically, longer RR1 was associated with better strain. And when they looked at strain values obtained from the cardiac cycles with RR1 by RR2 1, which means stable rhythm, then those values matched very closely with the values derived by taking average of all the cardiac cycles over 30 seconds. So instead of taking all that average, we just take this one single beat and we get accurate measurement. Other studies have also shown these findings using different systolic function parameters. Now, for diastolic function, the relationship between preceding cardiac cycle and the diastolic function parameters in the next cycle may not be that straightforward, but still, even there, this method seems to be working pretty well. And this is a study published in JACC Imaging in 2009. As we see here, uh, again, the investigators looked at 30 cardiac cycles. So when they took average of 30 cycles, it matched very closely with the single beat measurement derived using this RR1 by RR2 method. So basically, if we look at just these cardiac cycles, this is going to give us the most accurate measurement. Only thing is that we need to be careful that we avoid very fast heart rates, and it is always better to take average 2-3 cycles instead of just relying on one single beat. So now that we have decided what to measure, which cycle to measure, what parameters to obtain. So for LV systolic function, we need to look at LV volumes and EF. We need to use biplane Simpson's method for volumes and EF, and for that, it's very critical to match cardiac cycles. We need to use identical cardiac cycles for 4-chamber and 2-chamber views, which may be difficult many times. So there, if we have 3D, then it makes our task a lot easier because it takes away the beat-to-beat variability and it makes it simpler. For GLS, matching cardiac cycle is even more important because the software will not generate bullseye plot and will not calculate GLS unless the cardiac cycles are identical. So here we have three different views, 2-chamber, 4-chamber, apical long axis. The software by default picks the middle cardiac cycle, but here in this example, I have manually selected the cycles which have similar looking RR intervals, and only then I got the GLS value. So in our patient, the GLS was minus 19.2%, which indicated that the LV myocardial function, systolic function was at least preserved. Now, what about the diastolic function? The conventional algorithm that we use for patients in sinus rhythm is not going to be applicable here because we don't have EA ratio and we can't rely on LA volume. However, there are many other parameters that can be used. We can use distillation time of E wave. We can look at E over E prime, IVRT, ratio of E to flow propagation velocity. Then we can look at pulmonary vein flow, which is quite useful. And if there's L wave, it indicates high filling pressure and increased TR velocity. So I'll show you some of these in the next few slides. So this is the mitral inflow pattern in our patient. As we can see, multiple cycles have been averaged. Average value was 85 centimeter per second. This is annular velocity. In the guidelines, it has not been specified whether we should measure septal velocity or lateral or take the average. But the study from where the cutoff value of 11 has been derived, in that septal E prime was used. So I guess this is what we need to do. So here we have septal E prime, average is 6.9, E over E prime is 12.3, which indicates that this ratio is increased and LV filling pressure is elevated. So now here in this example, I have used I have measured E wave from different cardiac cycles and E prime from different cardiac cycles because there is no other option before us. But there are some echo machines which have dual Doppler capability, and in those machines we can do both the measurements simultaneously. And if we have that facility, then that is going to provide us more accurate measurements clearly. This was shown in this study. I showed you this study previously also, 2009 JACC imaging publication. So here on this axis, this is simultaneous measurement and this is conventional non-simultaneous measurement. What we find is that conventional measurement had decent, pretty good correlation with this simultaneous measurement, but for predicting elevated pulmonary capillary wedge pressure, conventional measurement was much less accurate as compared to simultaneous measurement. So if we can get simultaneous measurement, nothing like it. Otherwise, we will have to rely on non-simultaneous measurement of E and E prime. Then we can look at DT, dissolution time of E wave. This is applicable mainly when LVEF is reduced, but in our patient who had preserved EF, DTE was markedly reduced, 115 milliseconds, indicating elevated filling pressure. IVRT is a very simple and straightforward measurement, which we can do in most of the AF patients. If LA pressure is significantly elevated, then the mitral valve will open much earlier. IVRT will be short. So a short IVRT suggests elevated LA pressure. So this is a very simple and easy to obtain measurement. Here we have flow propagation velocity. This is again applicable mainly to patients with reduced EF, but in our patient, even this ratio was also elevated. It was 1.5. More than 1.4 indicates elevated filling pressure. Pulmonary vein flow, as I mentioned earlier, is very useful because in pulmonary vein flow pattern, systolic and diastolic waves are not affected by AF. So if we find that systolic wave is blunting, it indicates elevated LA pressure. So in our patient, there's hardly any systolic wave. It's just diastolic wave. So this suggests high LA pressure. And we can measure dissolution time of D wave also. So here it is roughly 160 milliseconds. Anything less than 220 indicates elevated LA pressure. So all these parameters are indicating significantly elevated LA pressure. Then we can also look at TR, PA pressure. So this patient had moderate TR, although TR gradient was not that high. IVC was dilated, which indicates that RA pressure is also elevated. This is another very important finding. LA volume was also measured. It was significantly increased, as was evident from the grayscale images also. LA volume index was 65 ml per meter square in this patient. So although we cannot totally rely on LA volume in this patient because, as I said, AF itself can cause this LA dilatation or LA cardiomyopathy can lead to such LA dilatation. But still, this tells us that LA is significantly elevated. And then I measured LA strain. LA reservoir strain in this patient was only 6.3%. Anything less than 25% indicates reduced LA strain. But those cutoff values have been derived from patients in sinus rhythm. We don't know what is applicable for those in AF, but 6.3% is definitely markedly reduced. This means that LA is hardly undergoing any phasic changes during the cardiac cycle. So what we found here, we found that the E over the E prime was raised, DTE was very short, IVRT was short, S wave in pulmonary vein flow was blunted, DT of D wave in pulmonary vein flow was very short, and there was elevated CVP and markedly reduced LA reservoir strain, all of them indicating high, significantly elevated LA pressure. At the same time, we found that the LVEF was preserved and GLS was preserved. So there was sort of some disconnect between these two. Either uh, the pathology affecting the heart has affected preferentially left atrium, and we are yet to see worsening of LV myocardial function with time. That seems actually to be the most likely possibility, but LA pressure is definitely highly elevated in this patient. So to summarize, assessment of cardiac function during AF is quite challenging. Averaging over multiple cardiac cycles, using multiple different variables, and looking at the underlying clinical scenario are helpful in reaching a reasonable conclusion. Thank you so much.